We're directly employed by Luft, but we provide a service within primary care networks within Liverpool. So Gemma and myself are working with Chilwell Wavertree, and Joanne is at, sorry. Oh, sorry. It's cut my foot out as well, so and then Joanna's at Swagger. So there have been some benefits with that integrated setup, especially in regards to transition to care and then going forward with the primary care sort of objectives. So the purpose of the clinic, obviously, we say patients are referred to us via the MDT. So we do have a foot within that MDT aspect as well. And what we do is sort of provide guidance and then initiate PCSK9 inhibitors. Obviously, that through the escalation process, I'll be optimizing the statins, adding in ezetimibe, and then going either with the bempedoic route or the PCSK9 inhibitor. Having said that, there's a lot of debate about inclisiran, I can never say it correctly, coming out. So at the minute, we're in talks about where that's going to be initiated and where it's going to be administered. Yeah, and obviously the ultimate goal is to treat the patient to get the LDLs down to a suitable level to try and reduce further rates of cardiac outcomes. So ultimately, this is just an outline of what we get into within the clinic. So patients are highlighted to the specialist clinic who are on maximised oral therapy. So that be that atorvastatin 80 milligrams plus ezetimibe 10 or rosuvastatin maximal dose plus ezetimibe. And if they're still not achieving those LDL targets, then escalated to us within, through that MDT route where they're highlighted the potential for PCSK9 inhibitor therapy. And that highlighted in green is just where we're at. And then obviously we initiate, prescribe, counsel the patients, send the prescription to the home care company who send out a nurse to train the patient on how to actually use the medication. And then we'll follow them up 4 weeks later and 3 weeks later, obviously 3 months later, sorry, repeating the bloods to see how we're getting on. So our role within the clinic sort of stretches beyond just prescribing. So we're there primarily for sort of a reference point as well. So we've had the time with the cardiac nurses, they'll come to us say, this patient is on X, Y, Z, is there anything to do with therapy, is there anything that possibly interact? Generally just doing our jobs as pharmacists, but also providing patient follow-up. So we speak to the patients, ask how they're getting on with the medication, sort of do a digging around whether they're actually compliant with the medication, because obviously it's to a questionable degree. And a lot of people, obviously people coming out of hospital with following STEMIs and STEMIs, bombarded with an awful lot of information, bombarded with ultimately 5 or 6 new prescriptions for a different medication that if they're trying to work out what they need to be taken and when, that's when you can get sort of compliance issues. And a lot of these patients may have only been on 1 tablet before, and now they're on 7 or 8. So digging into those, because if we expect, you want to make sure they're actually compliant with the medication before escalating or appearing to escalate therapy by increasing their lipid lowering therapies. So then following that, obviously then referred to the MDT and then referred back to us for the PCSK9 inhibitor therapy. And generally, obviously, within our roles is also that admin aspect where we're emailing and speaking to GPs about changes, making sure, or often chasing GPs up with those changes to make sure they're sort of transitioning transition through to primary care. Yeah. And what we've gained with this background, we've gained a lot more insight into the actual minutiae with regards to management of cholesterol. So not just treating the total cholesterol, but looking at LDL, looking at different levels and sort of what patient cohorts require more intensive therapies and sort of want lower LDL targets compared to others. So be it single vascular bed or multivascular bed disease. Again, it's also given us the confidence to go out back to our primary care roles and really sort of search how these patients are being inadequately managed. So instead of everyone being referred straight to the lipid clinic in our networks, sort of going through patient lists and identifying ones that we can escalate ourselves to the point that are manageable within primary care before escalating up to secondary care to try and reduce that burden within that within the primary care, secondary care clinic. Yeah, and obviously being very accessible within the networks. We've had a lot of sort of queries come through once the GPs and sort of A&Ps have realised that we are heavily involved in the lipid clinic. We are getting queries come through to us about sort of patient-specific queries about how best. We've also seen the point-of-care blood testing machine, which is fantastic. The turnaround literally has said 6 minutes to get the blood results. So you know, instead of making a change, prescribing, ordering bloods and having to wait sort of a couple of weeks at least to see any improvement, well, see the results of whether therapy is suitable. You can see it and sort of recommend therapy within 10 minutes. A little bit of a complex sort of slide, this. So it's basically just on the left-hand side in purple, is that, well, purple, yeah, leading purple and blue, let's say, is the aspect you're saying about referring to the MDT, escalating up the oral therapies, and making sure that people are trying to get people adequately controlled on non-injectables. And obviously that then, if we're unable to achieve the desired outcomes with orals, then they are then escalated into the orange route, where that's where you get escalated up into the PCSK9 inhibitors, where obviously we have a large amount of impact. So just about general background of PCSK9 inhibitors, there's 2 currently licensed. So you've got evolocumab and alirocumab, and they are injected every 2 or 4 weeks, depending. One of them, at the higher dose, is a 4-weekly injection. Obviously, they both have 2 weeklies. Subcut, and they're delivered by a home care company, which we've had some interest. We'll come on to that in a minute. It's been interesting, that ride. So clinical studies showing they cut the LDL cholesterol levels by more than half, showing that they are effective. And also there's good cardiac endpoints. There's some discussion around inclisiran, which I previously mentioned, that it hasn't got those cardiac endpoints yet, which is where a lot of the discussion is coming around with that. But yeah, these are showing clear benefit on endpoints with that, which is why ultimately the big drive to push them forward for the 14% of patients who are eligible. So they appear to be well tolerated because of MAB therapy, so monoclonal antibody therapy. Very few sort of reactions. Some people complain of injection site reactions, but within the studies there appeared no immune modulated reactions that you might expect from monoclonal antibody therapy. So again, tolerance is great. Quickly, how the PCSK9 inhibitors work. So PCSK9 itself is responsible for maintaining the low density lipoprotein receptors open on the hepatocyte cells, and then when that's resorbed, if that remains open, it's got a higher chance of being degraded and being broken down. However, if those remain in a closed position, they're more likely to be recycled and put back onto the hepatocyte cell surface to continue to resorb LDLs. So if you can sort of inhibit that PCSK9 with PCSK9 inhibitors, it increases the chance of those LDL receptors being re-upregulated and recycled onto the hepatocyte cell to then absorb more LDLs from the blood, hence lowering LDLs, circulating LDLs. So that's just the current nice technological appraisals for the two PCSK9 inhibitors. Obviously, so within our clinic, we're a non-familial hypercholesterolemia clinic. So we'd be looking at the top line here. So obviously, be looking at very high risk of someone with single vascular coronary artery disease. So that'd be sort of a single stenting, or someone who's had atherosclerosis in a single coronary bed. So needing the LDL cholesterol being greater than 4 millimoles per litre. And the very high risk, that's in 2 or more vascular beds. You're looking at 3.5 millimole per litre. And that would be sort of how you get access to PCSK9 inhibitors with, obviously they'd also have to be on maximum tolerated oral lowering, lipid lowering therapies. So I said we were largely responsible for commencing the patients on the PCSK9 inhibitors, so giving the prescription, sending them off to the home care companies. So these patients were escalated to us from the NDTs. That's when we would speak to the patient, give them a bit of counselling, say it's going to be an injection every 2 weekly to initially. We'll have another catch up in 4 weeks. Just basically explaining the whole home care aspect of it as well, because that's very new to patients, whereas specialist medication they used to either collect them in the hospital or if it's a general prescription, getting from their community pharmacy. So the home care delivery was something we really had to sort of get patients' heads around. Obviously, them self-administering this injection. Some people really don't like self-administering injections, so having to sort of say it's a tiny injection, don't really feel it, might feel like a bee sting at worst. And then obviously and obviously demonstrating it. Then obviously we had to continue to counsel the patients on lifestyle advice as well, to see patients' sort of lifestyles can slip. So everyone following an MI, they might make all of the correct changes, but then that begins to wane as they get bored of their new diets type thing. So yeah, it's just continuing to reassure the patient through. So a couple of patients we had were, so everyone's on evolocumab 140 every 2 weeks, the higher dose of 420 every 4 weeks. We've thought about for one of the patients, but decided against it for the time being, just because we've got most experience with this here. So that's a bit of a run through. I mean, one patient, I think we'll highlight that one patient on the next slide. So this is a female patient, 65 years old, proven medical history of anterior myocardial infarct with VF arrest times 3, and she's had a stent to the LAD in March 2020. Current meds were candesartan, aspirin, Lanzart, Bisart, furosemide, and GTN as you expect post post MIs. She had adverse reactions, she claims, to statins, which is why she wasn't on, couldn't tolerate any of them. And yeah, well, high dose aspirin but bleeding to teeth, but obviously that's more of a side effect. So yeah, she was intolerant to all statins and ezetimibe. So she's one of those patients that are often very difficult to manage. And she's a prime example of being escalated through to PCSK9 therapy, because there's no other way of reducing her LDLs down to a level that would be acceptable. So yeah, she was commenced on a PCSK9 inhibitor, and these were her results. So obviously total cholesterol, so prior and then following therapy. I mean, the LDL still a little bit high from where we want, but it's significantly better than 4.5 that it was prior to therapy. So this was when post MI, so huge risk, huge risk of a second event. So being able to have an impact, bring the LDLs down from 4.5 to 2.0, and all cholesterol down from 7.6 to 4.8 is going to have a huge benefit on her health outcomes going forward. Yeah, so that was just one of the ones that we've managed to sort of get through. So we've had the issues with home care. I'll touch on that shortly. So the learning outcomes for us, obviously within our primary care positions, we're able to use that lipid pathway to sort of lead teaching within primary care. So we're able to impart what we've learned onto GPs, so they'll be more intensive with regards to lipid modification following these events. But also, if we can get the interest within the secondary prevention, that will hopefully naturally lead through to the primary prevention aspect, where you'll get GPs really pushing patients to say, look, you're high risk, we want to really have an impact before you get that, because obviously prevention is better than the cure. So yeah, as I said, in the near future, hopefully inclisiran is likely to be coming coming to the party, but we're in discussion with NHS England whether that's going to be funded from primary care or be pushed through to secondary care. At the minute, there's just a lot of politics around it. Hopefully we'll get a one-stop clinic in either GP land or in secondary care, but that's part of the way going forward. And also it's really helped build and reinforce those bridges across secondary care, primary care, and community, and that we've all got experience across the spectrum. So we've been able to sort of highlight areas where often there's communication breakdown, and having access to both GP systems and hospital systems, we've seen where those interfaces can struggle. Yeah, that's nice. Yeah. Have we got any questions?
So there's a question from Susan Mason. What results do you get from the point of care testing machine? Is it a full breakdown or limited results? Yes. I think I can reply this, as my team is saying here, it's a full breakdown. So you get the whole lipid profile, which includes the total cholesterol, LDL cholesterol, HDL, triglyceride, and the non-HDL. So that's the reply. The next question is from Gemma Robertson to everyone. The main problem I have with patients who refuse to take statins are that they think they will develop diabetes or dementia. Are there any statistics or proof to show that the benefits of statins outweigh the chance of developing dementia or diabetes?
With regards to what was that, sorry?
The chance of developing dementia or diabetes. So I think I can reply this as well on behalf of the team. The statins, they have got a big data. A lot of evidence is there. If you look at the studies which have been published in BMJ or in Lancet, and we can send you one, where the statins, they significantly reduce the cardiovascular risk. And I think Prof. Fisher has shown his first slide, where you have all the statin trials on primary and the secondary prevention, which shows that reducing the LDL cholesterol by 1 millimole per liter reduces the cardiovascular risk by 23%. So it is well evidenced that giving statins reduces the cardiovascular outcome, and it also reduces the mortality in these patients. So there's a lot of robust evidence on statin. Now, regarding diabetes or dementia, now there is no clear evidence on dementia. It's very inconclusive evidence that the statins will can potentiate dementia in the patients. Regarding diabetes, there is a modest increase of diabetes, but again, you have to look at the risk and the benefit ratio of the statins. The benefit is much higher than the risk. And what we have seen in the diabetes study, if you look at the Jupiter study on rosuvastatin, that was the first study to say that giving statins can potentiate the risk of diabetes. So this diabetes risk is seen only in those patients who have got predisposing factors which can give them diabetes. So that is why the statins in patients who have got diabetes history of diabetes. Gemma, there are no more questions, but I think Marge has got some questions. Come on.
Yeah, you're right.
All I wanted to ask, you know, when someone is identified as public or cancer, BC, SK9 inhibitors, is there a waiting list afterwards? Is what sort of process is that before they can?
At the minute, it's quite a quick turnaround. Obviously, with the smaller cohort within the pilots that we're doing, it's escalated almost instantly, and then we see it. We're in clinic. One of us in clinic once a week, so the patient's reviewed within sort of 7 days.
I think they get their first prescription within 4 weeks of us sending the prescription over. They get delivery within 4 weeks.
And hopefully that's improving.
We should do, yeah.
We have had this. There's been a breakdown of communication with the healthcare at home company, but we've had a few meetings with those, and hopefully that's resolved now. So, I mean, we've had some promising talks where it may even be quicker than 4 weeks. Sort of, we send the prescription off via post, they receive it, and it should be with the patient within a couple of days, depending whether. I mean, the biggest sort of factor from their end, if it's a new initiation, obviously they have to find a nurse that's going to go out and train the patient on how to use it. So that could be the rate limiting step with an initiation from the home care company's aspect. But from us, it's almost a 7 to 10 day turnaround.
Yeah, I think I need to come up here, don't I? Otherwise no one will hear what I'm asking. I just wondered, George, you mentioned about inclisiran an issue with cost.
Yeah.
So there shouldn't really be an issue about cost of the product, but there might be other costs. So I just wondered if you could tell us a little bit more about that.
So at the minute, the inclisiran, obviously, NHS England were trying to push it through the primary care streams initially. So the acquisition cost of primary care was significantly less than in secondary care. There's been a lot of politics around that where the GP is obviously already very stretched with, and everyone across the NHS spectrum is very stretched, but GPs certainly have a lot on their plate with regards to, obviously, they're at the forefront of delivering the vaccine service. There is if the first sort of proposal was that if it was prescribed and issued through primary care, it'd almost be cost positive to the surgery to allow for funding of a nurse to administer because the injection is subcut, so obviously we can't expect a patient to be self-administering because you get one dose, the second dose is 3 months later, and then it's 6 monthly following. So that the £10 sort of supplement on top of the rebate cost to allow for the funding of a nurse to run a clinic to allow that to be facilitated. But at the minute that's gone back to the drawing board, and it's whether that's going to be allowed, whether that reduced cost can be available to secondary care as well, to start initiating in lipid clinics as well. Is it available now? You have to excuse me, I've been away for a few weeks, so I haven't really kept up the. It has gone through fine. Yeah, so I've been off for a good away for a few weeks, so things like that. Yeah. Yeah, thank you for
I'm fine because we only started in December. Like
yeah, we started quite late, so I feel like everyone's done the hard work, and then we've just come and slipped in. So I want to appreciate the support that we've had. Yeah, feeling welcome.